Hello, everyone, and welcome back to the 2022 Zero Prostate Cancer Summit on March 6, 2022. My name is Dr. Reggie Tucker-Seeley. I am Zero's Vice President of Health Equity, and greetings from sunny Los Angeles, California. Today, we're discussing health equity and prostate cancer. Thank you to Beatrice for sponsoring this session. And I'm joined today, I'd like to introduce Dr. Joseph Osborne, Chief of Molecular Imaging at Weill Cornell Medicine. Dr. Osborne, thank you for joining us today.
Thank you so much for having me. It's really a pleasure to join Zero and the audience who took time out of their Sunday to be with us and to discuss a really important topic. So thank you.
Great. So I'm excited to chat about health equity and prostate cancer today with Dr. Osborne and with all of you. So the title of our discussion today is Health Equity and Prostate Cancer. What is health equity? Next slide, please. So here's an overview of our presentation. Dr. Osborne and I will provide a bit of information about our backgrounds. I will talk about cancer disparities and health equity, and I will define those terms. I will talk about our work focused on health equity and some challenges to this work. Dr. Osborne will talk about health equity in clinical trials. And we will also provide some recommendations for what we can all do to work towards achieving health equity. Next slide. So whenever I attend a talk, or even when I was in college and in grad school, I used to always wonder how the person that was presenting got there. So at all or most of my presentations, I try to give a bit of information about my background. I often find that this also helps to understand what has informed my perspective and the work that I do. So I joined Zero in September of 2021 as the Vice President of Health Equity. And prior to that, I was the Edward Snyder Chair and Assistant Professor of Gerontology at the Leonard Davis School of Gerontology at the University of Southern California. And prior to that, I was an Assistant Professor of Social and Behavioral Sciences in the Center for Community-Based Research at the Dana-Farber Cancer Institute and at the Harvard T.H. Chan School of Public Health. And then between leaving Dana-Farber and joining the faculty at USC full-time, I was a Robert Wood Johnson Health Policy Fellow during the 2017-2018 academic year with the placement in Senator Dianne Feinstein's office working with her health policy team. So it is evident that my work is informed by my background in public health, gerontology, and health policy. Next slide. So now I invite Dr. Osborne to tell you a little bit about his background.
So in presentations in the past, I would talk a little bit more about where I came from. And my daughter told me that it just made it seem like I was quite old. So what I'm going to instead do is talk about my perspective and really where I'm coming from and what people always ask me when I present this work, which is what is Rad Health Equity? So I'm a professor of radiology at Weill Cornell Medicine, but I'm also the founder of Rad Health Equity. And the reason that we started it is because we saw that there was a gap. There were a lot of people, a lot of my colleagues talking about the very exciting imaging and therapy that was coming into the space, but fewer that were really talking about access and the patient's journey and how they deal with all of the components, including the determinants of health, to get to the point of equity. And as a physician and as a radiologist who is going to promote this space, I also have to find ways that I could bring my colleagues into the conversation of talking about the patient and their journey through the process so there is clearly equity. So I'm a radiologist. Radiation oncology is also part of the conversation. So you'll see Dan Spratt and Kostya Yamoa and Brendan Mahal, who actually talk quite a bit about the patient journey and disparities and equity. But for radiology, it's something a little bit newer, although there's all of this interesting information about imaging and therapy that you'll see later in Tomas Beer's talk that really is a part of where radiologists have to be a part of Rad Health Equity. So thank you, Reggie.
Hey, thanks, Dr. Osborne. And thanks for giving that information about your background and sort of helping us to understand what informs some of the things that you'll be talking about today. Great, next slide. So now we'll talk about cancer disparities and health equity. Next slide. And I'll start with talking about cancer in the Black community. So the image on this slide segments the research focus on cancer into distinct components: prevention, screening, diagnosis, treatment, post-treatment, survivorship, and mortality. And across this continuum, our living environments influence the outcomes of each component. For example, the economic, physical, and social environments in which we live can impact our cancer preventative behaviors, whether or not we can easily access screening, the quality of care we have access to, and the quality of our lives after treatment. And those living environments are better described as the neighborhoods we are often sorted into by our demographic characteristics, by such characteristics as race and income, are influenced by the laws and policies where we live. Now, Black Americans make up approximately 14% of the population, yet we have the highest mortality rates and shortest survival rates of any racial and ethnic groups in the US for cancer. And that is largely driven by differences in social factors. In particular, the influence of historical and present day differences in the social environments of Black Americans occupy compared to white Americans and other racial and ethnic groups substantially influences the health outcomes of this population. Next slide. Next. So we as a country have made progress in reducing the differences in cancer across racial and ethnic groups. In particular, according to the American Association for Cancer Research, the disparity between Black and white Americans in overall cancer mortality has decreased. In particular, they report the decrease from 33% difference down to 14% difference from 1990 to 2016. Now, note that this is for all cancers combined. Next image. So while we have seen the mortality rate for prostate cancer decline, which is shown in this graph, there's been a decline between Black men and white men. But what this graph also shows that as Black men are represented by the red line and white men by the gray line, is that the difference in the group remains. So even though there has been a decline, the difference between the groups remains. Next. In the Disparities report from the American Association for Cancer Research, we see that per 100,000 in the population, approximately 173 Black men will be diagnosed with prostate cancer compared to 102 white men, so over 1.5 times higher incidence. And from that same report, we see that for mortality, about 38 Black men die from prostate cancer compared to about 18 white men per 100,000 in the population, which highlights a 2 times higher rate of mortality. Next slide. So those differences are called health disparities. Now, this term can be used to describe differences across the continuum of cancer described earlier. And at 0, we define health disparities as differences between groups in health outcomes related to preventing, detecting, treating, and surviving prostate cancer. And some examples of these differences include some of the racial differences that I've talked about earlier, but also racial and ethnic differences in screening behavior, racial and ethnic differences in treatment, place-based differences in the quality of care received, and socioeconomic differences in quality of life after treatment. Next slide, or next term. So we know that it's very hard to be healthy without access to fundamental resources such as affordable homes in safe neighborhoods and employment that provides sufficient resources to cover at least basic needs. Efforts to ensure that everyone has the opportunity to be as healthy as possible is called health equity, where this means everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. And this is our aspiration at 0. This means that we must work to ensure that everyone has a usual source of health care, to get screened for prostate cancer, coordinated high quality of care so that individuals can easily move from primary care to specialty care if necessary, and that families have the resources they need so that navigating and managing prostate cancer is not financially ruinous to the household as they navigate primary and specialty care. Next slide, please. So why do these differences in health exist? So we know that across and within sociodemographic groups, there are substantial differences in the environments in which individuals are born and where they grow up. In particular, if you think about the city where you live, you will note that we are often sorted by specific demographic characteristics. Oftentimes it's income and race, and the neighborhoods across these characteristics can be very different and contain very vastly different health promoting and health damaging resources which influence our health behaviors, and our access to and how we navigate healthcare. In addition, those socio-demographic characteristics have shaped where we work and how we are navigating aging and managing getting older. Collectively, the conditions where we live, learn, work, pray, and age, and the factors that create those environments are called the social determinants of health, or SDOH. They're in the middle. And this graphic from Healthy People 2020, and Healthy People 2020 is the federal government's program designed to guide national health promotion and disease prevention efforts, outlines 5 domains of the social determinants of health, which are our neighborhoods and the built environments of those neighborhoods, the healthcare we have access to, our social community contexts, our education levels, as well as our level of economic stability. Next slide. The National Cancer Institute brings all these factors together. And so this graphic here actually, I think, is from the American Association for Cancer Research, but it depicts the definition or the description that's provided by the National Cancer Institute, where they state that cancer disparities reflect the interplay among many factors, including the social determinants of health, but also our individual behaviors, our biology, and genetics, all of which have profound effects on our health. Now, as researchers, support education and advocacy organizations, and healthcare providers, it is our role to identify the modifiable factors. That is, what can we change to reduce or even eliminate the differences in outcomes across that cancer continuum from prevention to end-of-life care? Next slide. While our definition of health equity is specific to our efforts in prostate cancer here at Zero, the CDC offers a more general definition that states that health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or other socially determined circumstances. Next slide. So what are we doing at Zero to work towards achieving health equity? Next slide. As obvious from the definitions of health equity I've presented, this is an aspiration. And we at Zero are working towards putting an end to prostate cancer. And we can't do that unless we put an end to prostate cancer for everyone, and not just for those with a higher social position or more social resources. And so our health equity team includes myself as the Vice President of Health Equity. We have recently hired a director, Chris Bennett, for health equity, community organizing, and engagement. And we also have a racial disparities task force, which just this week, we changed our name to the Health Equity Task Force. Now, our work on the health equity team is focused on 2 key questions. The first question is, what does an equitable cancer care delivery system look like? And how do we prepare Black men to expect and get equity as we are navigating the healthcare delivery system? Specifically, what tools are needed to ensure equity? Now, you may be asking why the focus on Black men. As was mentioned earlier, Black people generally have the worst health outcomes for any racial and ethnic groups when it comes to cancer generally, and Black men are over 2 times as likely to die from prostate cancer compared to white men. So while there are differences in prostate cancer related outcomes by other characteristics such as place and socioeconomic status, We at Zero are first focusing on the disparity experienced by Black men. And this focused approach ensures that we can actually make a difference on this disparity and then use what we learn from that process to inform our efforts to focus on other disparities. So how are we implementing our efforts here at Zero focused on health equity? So first, we're focused on thought leadership. That is, we serve on national boards and committees, and we're continuously raising the issue of prostate cancer disparities and working towards solutions to address these disparities. For example, members of our health equity team serve on the American Society of Clinical Oncology's Health Equity and Outcomes Committee and chair the Social Determinants of Health Task Force on that committee. We're working to convene and collaborate with community and research partners, and we're working towards creating pathways for collaborating internally with our policy and advocacy teams and our patient and programs and education teams. Next slide. So for those of you that attended our Racial Disparities Town Hall back in September when I first started, you will remember that I talked about this framework for how we plan to work on addressing disparities here at Zero. We started with getting organizational alignment on how we define terms. So those terms that how I define health disparities and health equity at the beginning of this talk, those are our organizational definitions for these terms. And next, we move to selecting specific health outcomes to focus on. So are we focused on screening? Are we focused on treatment? Are we focusing on health-related quality of life following treatment? And then we identify specific data sources for evaluating those health outcomes. We explicitly measure the differences and explain clearly how they are measured. We partner with communities so that they can identify and implement solutions that work for them. And we include evaluation so that we can measure how well we are working towards achieving health equity. And this framework will guide all of our health equity efforts here at Zero. And for those that are interested, I worked on a paper with several colleagues, including one from our Health Equity Task Force, Dr. Sherry Wallington, on the paper called Health Equity for Older Adults with Cancer that was published in the Journal of Clinical Oncology. The citation is there. So next slide. So I enjoy working in this space. I enjoy figuring out sort of how to address health disparities to work towards health equity, but I recognize that there are challenges in working in this space. Next slide. So one of the major challenges of working on addressing health disparities is that most Americans are unaware of health disparities. They do not understand what causes health disparities, and they lack the appreciation of the unfairness in these differences. Now, recall that the definition of health equity is that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. So if one doesn't view the differences between racial and ethnic groups as unfair, that can make it hard to move towards addressing those differences. Next. So in a survey about a decade ago, people were aware of differences in health by class. That is, that rich people generally have better health outcomes than poor people. But fewer people were aware of racial differences. And for those that were aware of the racial differences, they attributed those differences to individual behaviors. Now, recall in our discussion about social determinants of health that it is important to realize that individual behaviors, or the choices for individual behaviors, are often shaped by the social environments in which we live. And across racial and ethnic groups, we often live in very different social environments. So next slide, please. So one area where we often see substantial racial and ethnic differences in the treatment space for prostate cancer is in clinical trials participation. And so now I will turn the presentation over to Dr. Joseph Osborne to talk about health equity and prostate cancer clinical trials.
So thanks again, Reggie and Zero, for giving me time to discuss this perspective in prostate cancer clinical trials. And thank you to all the live participants. So I'm going to keep my remarks brief and really lean on some of the content given by many of the dynamic speakers in this agenda, who will touch on many of the aspects of clinical trials in their talks. But I want you to also have a little bit of time after this is done to have questions and join the conversation with me and Reggie Tucker-Seeley, and a lot of the work and the foundation that has been given us by the Health Equity Task Force that has done this for many years before I joined. So next. So first, the first component of what I want to do is talk about some of the individual aspects of clinical trials and clinical trial participation and some of the systemic aspects of it. Just an example. And then one example in particular of the barriers to participation in trials, which is just the eligibility. And then discuss some of my goals, our goals, to getting past some of these barriers and what we could do and think about in our next steps. For this presentation, I have no relevant disclosures because I'm not going to talk about any particular product. Next slide. So one of the really exciting individual components of this, and many of the talks are going to focus on this, is that there is an enormous energy behind all of the new imaging and therapy, particularly PSMA, which is going to be talked about by Dr. Beard next, for prostate cancer. This is a new place where we could really find and define how to look at and also treat cancer. And at the same time, there's precision genomics. And this allows us to further and further individualize cancer imaging and treatment, and will certainly lead to better survivals. And you can see that in some of the curves that Dr. Seeley had presented before. Things are getting better on an individual basis. When you saw the decline of the cancer mortality in Black individuals and white, it was going down. But you still had this persistent difference between the two. And that's something that we'll talk about with systemic. Next slide. So another very important individual component of this is, it's me and my perspective. And your perspective changes rapidly when it's both professional and it's personal. So professionally, I am very interested in prostate cancer imaging and therapy, but of course, I am a 50-year-old African-American male going to my first prostate cancer screening visit where they took a PSA. And what do you think about at that time? You think of, or at least what I think about, and that's that men of African ancestry have disparities in incidence over 2 times. And then there are disparities or differences that are seen all along the treatment journey, from just treatment, access, death. And you think about that and you say, well, what about this applies to me, specifically as an African-American male who's also a physician? And what are the things that could change? And what are the systemic barriers to this change? And what can I do about it? So next slide. Next slide. So when you look at some of the systemic efforts, you realize that there are certain things that have to change, even when large organizations such as the National Institute of Health, who had the Revitalization Act signed into law in 1993, requiring women and members of minority groups and subpopulation to be included in all NIH-funded clinical research. In 2009, there was mandatory reporting of ethnicity and race. But 26 years later, the enrollment of African Americans and Hispanics into these trials is actually not improved. And it may have actually even declined. There is a theory that some of this is because of the additional requested genomics in many of these trials, but it's important to know that systemically, this hasn't really changed. So something else has to happen. We can no longer just do this and assume that these differences, this disparity is going to go away, because systemically something is pushing against this, right? So next slide. One of the systemic barriers, which I had alluded to earlier, is access and cost. So any discussion about the participation in clinical trials has to include cost, financial toxicity, and access. Because if you look at this graphic, for a Asian, Black, Latinx family, it's 81 cents, 6 cents, and 7 cents on the dollar. And these are 2014 stats. These stats were more or less the same in the year 2000, more or less the same in 1985, and more or less the same in 1965. And when you think about attribution, when people believe that things are fair or unfair, one thing that hasn't changed, the notion of racial progress and the notion of wealth hasn't, they're really two different things, right? And so if one is going to address the financial toxicity and getting into trials, if you can address cost, these things are going to appear as disparities as long as we're having this discussion about trials. So it has, as long as you have a situation where you don't have universal health care, one must also always address the social determinants of health and talk about cost, or there's really not much that we can do to untangle race and ethnicity from disparities. Next slide. So this was apparent before. So one of the things that we must learn is that just because you have a brand new technology doesn't mean that disparities go away. Disparities and health equity can actually get worse. And this was the case with colon cancer. When colonoscopy, it was clear that screening colonoscopy was going to improve overall survival, but colonoscopies weren't available everywhere, right? So what you saw over these number of years, this is tracking from 1973 to 2003, you actually grew the disparity by only having colonoscopies available to some. So as Reggie said, unless it's available to all, we're not able to do this. And in fact, when I look at imaging and therapy as an imager, and I see all these exciting things, I say, well, if I don't make sure that everybody has access to this, I could actually be making this disparity and equity worse. So before this becomes widely available, I have to make sure it is available to everybody. Next slide. And this was comprehensively looked at in the Institute of Medicine's Unequal Treatment. And what one finds when you look at the statistics is that many of the disparity statistics have not changed in 40 years. Next slide. Uneven progress leads to uneven treatment. So progress has to be for all. Advance. And you have to start with participation in screening programs and new clinical trial design from my perspective. If you don't design it well in the beginning, you have to expect that things aren't going to work well downstream. Next slide. So this is a slide from the National Cancer Institute, the Center to Reduce Cancer Health Disparities. And it's a busy slide on purpose, which is to show that when you want to talk about cancer care and use and access, there are so many angles that one has to look at. And so no single person or single organization even can tackle all of them at the same time. But you have to focus on the things that one can change and see whether those levers that one has will make a global difference. So advance. I am going to talk just about one thing because I have a limited amount of time, and I think it's actually quite important for imaging trials, and that's eligibility requirements. Next slide. So we have learned a couple of things. So referring back to my earlier slide, when I was thinking about my 50-year-old physician visit with a PSA screen, men of African ancestry, 2.2 times, disparity in treatment, but these all exist in the context, not only of race, but socioeconomic level, education level, zip code, or place. There are many aspects of what this might mean, which is one of the reasons that we are going to talk as a health equity task force, because there are many aspects to what self-reported race really means here, right? Because when you look at clinical trials, which is really important, despite presenting with more advanced disease, self-reported African-American patients demonstrate favorable outcomes in clinical trial context. And so that's telling you, when you put it in, when you have African-American men who are able to join a clinical trial where things are really regimented in terms of treatment, they do much better. And that says that the causes of self-reported race in these trials, or in the context of prostate cancer, is much more of a social construct than it is actually race. There are important components of race, but one has to really drill down to the drivers of what it is in order to get equity. And that's what we want to do. And when you look at men of African descent, they tend to have favorable outcomes in clinical trials. So for me personally, I'm like, how can we broaden clinical trials? How can we make the eligibility easier so most people who want to be in clinical trials can get in clinical trials? And how do we have it so that people who get into clinical trials are protected from the financial toxicity that can happen during the patient journey? Next slide. Next slide. Okay. So when you look at clinical trial participation, and I'm interested in all aspects of this, of course, but I'm going to drill down again to eligibility, because when someone presents initially to become potentially part of a clinical trial at a research optimized site, there's still several steps, at least 5 steps, in which the number of eligible patients whittles down to the ones who can actually be a part of the trial. But when you look at eligibility, there's some very important aspects to that. So next slide. One of the things that I believe is that eligibility criteria, and when you look at it, when you look at eligibility criteria over time, from 1999 to 2005, the median number of eligibility criteria increased from 31 to 49. So the eligibility criteria are actually getting more stringent. Some of that is good research. Some of that is to be more careful, but it's something that we have to think about it. Why are those requirements coming up? Because we have to find ways to adopt less restrictive eligibility criteria, because we know that it'll result in more rapid accrual, broader generalizability, because there's this argument between clinical trials and real world data, because sometimes things look different post-approval, right? But we should actually try and get clinical trials to look maybe a little bit more like the real world, but I think clinical trials are much more important in determining whether things actually work, right? but we need to reduce the complexities and the costs. If we're asking people to do additional imaging or additional tests that are not covered, we have to really think about whether that is necessary. Whenever possible, if something isn't 100% necessary, we have to eliminate it, because people look at that. They want to be a part of the trial, but if you say, yeah, you can be a part of the trial, but it's going to cost you $10,000 a year, maybe it's something they think twice about, right? Maybe there's another way. And we don't want to be, as physicians, as institutions, we don't want to be that barrier to participation. We want to have more patients, and certainly more African-American patients, part of these prostate cancer trials, so we can determine what works and what we can do. Next slide. So the way that I look at equity, and this is a part of clinical trials, is that it's roughly the equation is population health over systemic bias. So whatever ways we can influence improving population health and decreasing systemic biases, knowing that we can't control everything that's systemic. We definitely cannot, but we have to do our best. And there are many different roads. And that's why we're here with many people part of the conversation, because everybody has a part in this, actually, right? People who are politicians, people who are, everybody can be a patient, right? Everybody is impacted by cancer in their family. And this is something that everybody has to understand. Everybody is a part of this. When there is equity, the whole population does much better. And what we have to do as imagers, but also as physicians, is to optimize care that adheres to the patient's values, environment, and location. If care means we have to find ways to make sure it's closer to home, and we find more ways to be in more places, that's what we have to do. If we have to make sure it's done on certain days, in certain ways, in certain times, adhering to other, we have to figure out how to get across those barriers. And so we have to prioritize access to care and quality care that includes greater inclusion in clinical trials. Again, for me, eligibility. And make room for a greater genomic diversity and inclusion past self-reported race. Self-reported race is important, right? But what we clearly need to do is to include more genomes, if possible, of patients of African ancestries into these trials. So once we have a broader view of genomes, whether it be African descent or other, this is how we're going to do better at treating patients in the next iteration. This is how we learn more about some of the emerging agents that we talked about earlier, like STEAP or like DLL3. These are things that we need to understand by including the patients and also finding ways to have their genomes included. Next slide. So when I think about clinical trials and participation, I think about how do we start this? If I were to start a clinical trial, what would I think about? So one has to address site selection. The catchment is important. The patients you want to capture and learn about have to be in the catchment. They have to be around. You know, a lot of times, and I've seen it, the selection of sites is based on physicians, champions, and that's important too. But if the patients aren't there, we aren't going to be able to learn. So somehow we have to address catchment. Next. We have to address access to care issues. How far are you away from the site? Navigation, financial toxicity. These are some of the things that Reggie was talking about, even within the site, for Zero to look at, well, where's your nearest clinical trial? How do you get there? Who's going to help you? How much is it going to cost? Who is there to help? Who's been there before, right? That's all going to help. Next. And we want this enrollment and participation, as I said before, to include the genomic analysis of men of African ancestry. Everybody learns more by having those genomes. Next slide. And we need to bring the patient voice into clinical trial design, eligibility, and cost before the trial begins. And this is something I haven't seen much done with, but I think it's very important, because if you want to know how to give the patient access, you have to ask them. You have to know what it is that you may be doing wrong as a practitioner or as a company in order to get people in. And so the most powerful advocates for patient participation will be the patients themselves. And so they must be heard. And so, next slide. In summary, before we move on and talk about these issues more broadly, I wanted to talk about individual and systemic components to this. And the systemic is much greater than even I can present here. There are many things that we have to consider, but the individual is important too, because one has to figure out what you can bring, whether patient, provider, advocate, to the conversation to make things better. We have to look at the barriers for participation. I am going to myself be a part of starting several trials in the next couple of months. And when I do so, there's going to be a patient advocate involved, because I think we have to look at this very carefully. And for my goals are hopefully what your goals are. Certainly my goals are everything laid out extremely well by Reggie Tucker-Seeley, which is to find ways to have organizations really embody all of these things that we need to bring into clinical trials and into prostate cancer. So, next slide. I would like to reimagine this with patient voices. I think what we'll find, what we'll hear, even over the course of this several-day summit, is that the patient voices are incredibly powerful. And the more we listen, I think the better that we get. So thank you very much, Reggie, and Zero, and our participants.
Right. Thank you so much, Dr. Osborne, for illuminating the barriers to clinical trials participation and the role of differences in that participation that contribute to disparities, and the importance of having patient voices in clinical trial design and implementation as we work towards health equity. Next, I'd like to highlight another pathway to address racial and ethnic disparities in prostate cancer, and that is to increase communication within families about our health behaviors, and how we are navigating healthcare. Our Vice President of Patient Programs, Shelby, who you've seen a lot during the summit, recently sent me this video that we're about to show you, and I was so impressed with its content that I thought I have to add it to our discussion here today related to health equity. The short film is called Embarrassed, and it was released by the Male Cancer Awareness Campaign in Europe and it was directed by Sir Steve McQueen, the director that brought us 12 Years a Slave. This film and subsequent campaign were created to help raise awareness about prostate cancer within the Black community. Please roll the film.
Embarrassed. Too embarrassed to speak to a loved one. Too embarrassed to speak to your doctor.
Too embarrassed. When in our lifetime, 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer.
Let me repeat that. 1 in 4 Black men will be diagnosed with prostate cancer. 1 in 12 Black men will die from prostate cancer disease.
1 in 12. That could be your dad, even your older brother, uncle, or grandfather.
You need to make sure they are not embarrassed to speak to you or their doctor about it.
Hey, Dad, have you had your prostate checked out? See? How hard is that? It's easy. Just start the conversation.
Prostate cancer is survivable if caught and treated early enough.
Don't let embarrassment stop you having this important conversation.
You may save someone's life.
Not just your own.
So I hope that you enjoyed that film, and I hope that you will share it widely so that we can ensure that more families are having this conversation and working towards addressing the substantial disparity that we see, that we've talked about today, that Black men experience related to prostate cancer. So now that we have defined health equity, that is the notion that everyone has a fair and just opportunity to prevent, find, treat, and survive prostate cancer. We've discussed how barriers to clinical trials participation contribute to health inequity, and the importance of starting the conversation within our families, especially within Black families, as a way to work towards health equity. So I hope that this discussion has given you many things to think about in terms of health disparities in prostate cancer and our need to work towards health equity to end prostate cancer for everyone. So now we'll take a couple of questions from the audience. So I saw that there were a couple. So let me see. The first question is, so we'll bring Dr. Osborne back as well. And so he and I will have a conversation about the topics that we've talked about today. And we'll look to see if there are any questions from the audience. I see one here is, so Dr. Osborne, related to clinical trials, what is the best way to get involved with the clinical trial? And are clinical trials safe and trustworthy?
Okay. So one of the ways to get involved with a clinical trial, there's a platform, clinicaltrial.gov, that has a lot of the curated clinical trials that are at different institutions. Those clinical trials, which have been vetted, are certainly safe and hopefully will be descriptive. I think what we're trying to build going forward is a little bit more information, because there's so many options, right? When someone hears that they have cancer, it's hard for them to hear anything else for some time, right? Because that's they're thinking about a lot of things. Clinical trials is not one of them at that moment. Once one is able to hear, when someone is given 30 options, one has to think, well, what's the right option for me? Is this the right option? And which one of these 30 is actually going to help? Which one is safe and which one is effective? And that's going to be a conversation that I think has to happen between the provider. But I think that is something that we and Reggie at Zero are trying to help curate, because getting through the journey is actually much more difficult than going to clinicaltrials.gov and seeing what's there. I mean, what's there is going to be all of the great curated, medically safe trials, but what kind of trial are you able to do near you? What kind of trial is going to adhere to these values, to the participation, to the cost, to the efficacy? Those are things that hopefully the provider can talk about, but I think we want to build more information at zero. So also patient advocates can say, well, this, or patients themselves, former patient, well, I did this trial, was my experience. Advocate, well, these are the ones that are available in the New York area, and this is someone you should talk to. Because I think the conversation needs to come from many different people and not just a website.
Mm-hmm. Mm-hmm. Well, I see we have another question, and this question is specifically for you, Dr. Osborne. It says, if you did a study on 100 Black college professors, 2 from each state at age 70, and compared them to 100 white college professors, 2 from each state and also 70, would the percentages be similar? And I'm assuming that by the percentages, they're meaning would the prevalence of prostate cancer be similar in those groups?
So what I'll do is sidestep this question just ever so slightly and talk about a study that was performed and published by Kosje Umoa, where he was looking at gentlemen in the VA system. Mm-hmm. The thought was, since they have pretty equal access to services, it should be pretty much the same if there are no actual racial component, right? Mm-hmm. What you do see is that there is a slightly higher incidence, and that there's residual excess death by metastasis, mm-hmm. right? And I think when you equalize treatment, you get close. Mm-hmm. But even within a VA system, just like being, a professor, you're still affected by the social determinants of health. And we've known this actually for several decades, since there was a study that looked at physicians who graduated Fisk, which was a historically Black college, and med school at the time. And I believe they compared it to Hopkins. And the physicians, the Black physicians from Fisk tended not to do as well as the white physicians who graduated from Hopkins. And that's because, being a professor is great, but you're still living in the world that you're living in. And there are other things that impact your health. And these things have to be, it's sort of a discussion. The philosophy is that there is still that world out there of systemic things. But yes, I would imagine it would be closer.
Yeah, and so and you bring up a really good point there in your last statements, because there's been a lot of research done in social epidemiology, specifically by a researcher named Dr. David Williams, who's the chair of social and behavioral sciences at the Harvard T.H. Chan School of Public Health, and many others in the field, sort of highlighting that that for increases in socioeconomic status. So as we go up the socioeconomic ladder, that the benefits of that are more for our white counterparts than for Black individuals. So at each of those stages, even when socioeconomic status is comparable, the white individuals do better in those strata than their Black counterparts. And so a lot of research in social epidemiology supports that notion. Okay.
And anecdotally, you'll see it. I mean, if you want to look at the physicians of color, mm-hmm. Even in the radiology department, if you want to find 5 hypertensive Even controlling for age physicians, you go to the Black physicians and you'll find them very quickly, right? So there is a difference.
Mm-hmm. Yeah. So my last question here, I'm actually going to pull from something that you and I have talked about in sort of preparation for today, and that is there's often some confusion between equality, so that is treating all patients the same, versus equity, meeting patients sort of where they are. So what can providers do to ensure that they are approaching care with an equity lens?
So I think it's important to look at people or patients who, physicians have seen in the past as, this is a non-compliant patient. Oh, this patient refused to do X. And they don't look at it as, well, I wasn't able to talk to them in using the correct things that really matter to the patient so they could actually get to the answer yes. And, when you get to yes, you'll probably see equity. I mean, if you treat everybody the same and then half the patients are walking out the door because they're like, I don't want to do that, then that's not working. And there's something that you're saying that is driving that inequity in your practice. A lot of physicians don't see it. They haven't seen it because they'll say, I treat everybody the same. And they do. But that same way doesn't work with everybody, right? So if someone isn't, one of the things that you'll hear, Black men are really fatalistic. They're like, that's it. I had prostate cancer. I'm done. I'm not going to be treated. But a lot of it is, if you say, well, it's going to cost like $10,000 a year. This is going to happen. That's going to happen. So I'm like, I'm not going to bankrupt my family. It may not be fatalism. It may be the reality that treatment is going to do things to their entire family that they will not allow to happen. Right. So I think there's a big difference, and people have to ask the questions that they haven't asked before about why someone actually doesn't want to do, says no.
Yeah. Yeah. Great. So if we can pull up the slides, we have only a couple more minutes left. I have some closing slides that I'd like to present. Thank you so much for this conversation, Dr. Osborne. So I realize we've covered a lot of information this morning, and you may be asking yourself, what can I do to tackle something so big as health disparities in the US? So we've broken down our recommendation into multiple levels. So first, what can you do as an individual or family? Well, first, you're doing it. Attending events like the Zero Annual Summit to learn more about prostate cancer, to share your prostate cancer journey, and to learn more about health equity and health disparities related to prostate cancer. Next is participate in research. We need your perspective, and we need multiple perspectives across racial and ethnic groups in community-based research, in clinical trials, and other types of research studies to ensure that the findings represent the experiences of all groups. And next, talk within your families about health generally and prostate health specifically. I know this one can be hard. It's a challenge I have with my own family, but we have to do more of this if we are to understand the familial connection of prostate cancer and to help remove barriers for navigating the healthcare delivery system. Next. So second, for healthcare providers, researchers, healthcare delivery systems, and community-based organizations, be explicit about defining terms and what specific disparity is being addressed. Are you focused on racial and ethnic disparities, geographic disparities, gender disparities? Is the disparity in screening, treatment, quality of life, end-of-life care? Be very explicit about the disparity you are addressing, because as you saw from that slide that Dr. Osborne showed, there's so many factors that contribute to the disparity that being explicit about the language and the specific disparity we're focusing on helps to focus our efforts and ensure that we're actually working towards the same goal. Move past describing disparities to interventions on disparities, and this includes evaluation. As someone who has led and participated in public health and healthcare delivery related research, I know that we've done a good job of describing where the differences are, but we've done less work on actually intervening on those differences and in developing sustainable interventions to eliminate those differences. More work on the pathway leading to disparities and being more open and honest about conversations related to racism and other isms. We're going to have some very difficult conversations about our history that has created the different social environments that we see across racial and ethnic groups, and the impact of those differences on our health behavior, and how we navigate healthcare. We can't be afraid of having those conversations and looking at how we can right those historical wrongs to work towards achieving health equity. In doing this work in the healthcare delivery space, we're going to have to center the patient experience and the patient voice in research and policy advocacy. And next, think and act at multiple levels: individual, community, systems, and policy levels. This one can be hard to think and act at multiple levels simultaneously, but we're going to have to focus on those systemic issues that Dr. Osborne mentioned, but also on the individual levels and on the policy level to really achieve health equity. And last, for our policymakers, fund research that focuses on intervening on disparities. Develop and implement policy that explicitly targets eliminating disparities across the cancer continuum from prevention to end-of-life care. So while policies that take a general population approach are helpful, we also need policies that explicitly target not only lowering risks and rates of poor health, but also on reducing and eliminating differences between groups. Develop and implement policies so that a cancer diagnosis is not financially toxic to the household, and eliminate financial barriers to screening and treatment. Now, these last two are imperative so that navigating cancer care is not financially ruinous to the household. Research on financial toxicity and financial hardship in cancer has increased. In particular, that works describe this phenomenon and is now moving towards work on developing and implementing interventions. And hopefully this work will highlight the most effective pathways to action to create health equity. Next slide. So when I give talks on health disparities in cancer or talks that I've given on financial hardship, I always end with this quote by Dr. Fitzhugh Mullen, a physician and cancer survivor. And I think it's quite relevant, still relevant today. Despite the success on the cancer treatment front, we have done little in a concerted and well-planned fashion to investigate and address the problems of survivors. It is as if we have invented sophisticated techniques to save people from drowning, but once they have been pulled from the water, we leave them on the dock to cough and splutter on their own in the belief that we have done all that we can. So I'll end with a quote from a meeting where I'm paraphrasing our CEO, Jamie, that one of our primary goals at Zero is to make sure that no one goes through their prostate cancer journey alone. And I think this quote captures what we at Zero are doing to work towards health equity and to address the thing that Dr. Mullen was mentioning, so that we've not done all that we can. We want to work towards health equity to ensure that as we work towards bringing an end to prostate cancer, that we indeed make sure that all groups cross that finish line together and we leave no groups behind. So thank you so much for attending this session today. Thank you so much again to Dr. Osborne. Thank you again for your participation and support in the Zero Prostate Cancer Summit. Thank you all for attending this session. So you can learn more about Dr. Osborne in the speakers tab on the left of your screen. And thank you again to Viatris for sponsoring this session. You can learn more about Viatris in the sponsors tab. And the Zero Prostate Cancer Summit is far from over. We're going to take a short break and we'll resume at 1 p.m. East Coast time, 10 a.m. West Coast time. So please enjoy this break and feel free to explore all the recorded sessions we have for you in our on-demand tab or chat with other participants. And we'll see you back here soon. Thank you.